Well, thank you all for having me, and I'm sorry I couldn't be here yesterday. As usual, I try to juggle about 20 million things and thought that I would reschedule the patients that I have for this afternoon for tomorrow morning and realized Portland is more than an hour and a half away from Boston. And thank you to Tori and to Jonathan for inviting me. I have a long history of coming up to Maine to work with Tori. Since 2004, Tori. I think I'm dating myself, but it's really wonderful to be here. So Jonathan and Tori asked me to talk about what to do with the young child to prevent lifelong obesity. And I think I saw some of the presentations yesterday, and I know that I probably do not need to cover the prevalence of childhood obesity. I think now that was probably, you probably are all well aware of the obesity epidemic. So I'll go through those slides a little bit quickly, because what I wanted to spend a little bit more time talking about were some established early life risk factors, evidence-informed policies and recommendations on assessment, prevention, and management of obesity in early childhood, and walk you through the findings of the Institute of Medicine report on early childhood obesity prevention policies that was released last year, and was one of the first reports that recommended or made recommendations on what we should be doing to manage childhood obesity or prevention of childhood obesity from birth to age 5. So it's really exciting. I was part of that committee, and really exciting to have that report out there. And then I'll walk you through some pilot interventions or interventions where we've tried to put some of these recommendations into place. Some of them are ongoing, others are completed, but just to give you a sense of how we've attempted to put some of these recommendations by the Institute of Medicine into practice, and some of that will be related to sleep, and I'll cover that a little bit later. So you all are probably familiar with the childhood overweight and obesity epidemic in the United States, and this slide just shows that the epidemic hasn't spared other countries. It's pretty well known that although the United States has the distinct privilege of being the light blue line in this figure, across all countries globally, there's starting to be, after the nutrition transition, we're really dealing with malnutrition. We're now starting to have flipped that around, and almost every single developed country in the world is facing issues with overweight and obesity. We care because childhood obesity is prevalent and of consequence. This is a wonderful figure, actually, by Cara Ebling and David, that pretty much shows what we all who practice obesity management tend to see in our patients who are overweight and obese. We care because obesity is not only prevalent, so 17% of children ages 2 to 19 years are obese, but it essentially does not spare an organ system. And we're all pediatricians in this room, but I tend to be in the room with a lot of internal medicine researchers who tend to think that we care about obesity because it's going to lead to adult heart attacks. But actually, we care about obesity because there are pretty significant morbidities in childhood. And more are these kind of silent morbidities where we see so much depression, self-esteem issues, and the impact that that's going to have, not just during childhood, but if that tracks throughout adolescence and adulthood, it's pretty substantial. So I care because obesity is associated with both short and long-term adverse outcomes, and there are pretty substantial comorbidities during childhood that, if we could prevent obesity, could make pretty significant impacts in the life of that child. The other important thing is that obesity disproportionately affects racial ethnic minority children. So while there's, in the most recent evidence from N. Haynes, there's some appearance of what looks like a plateau in the rates of obesity. In 2010, just to give you an example, 14% of white children, 24.3% of black, and 21.2% of Hispanic children, 2 to 19 years, were obese. So although the rates seem to have plateaued, they're still pretty high. The prevalence is high. And it looks like there are widening of the disparities between white and non-white children, and it's concerning. So, we hear a lot in the national discourse about, we might have reached a plateau in obesity, which is fantastic. But what we don't hear as much in the national discourse is that the prevalence is still high. We still have a job to do. And that these racial ethnic disparities are starting early. By 2 years of age, we already see these significant disparities. And those gaps appear to be widening. The other thing that's pretty striking is that the obesity epidemic hasn't spared the nation's youngest children. And this is one of the reasons for the report that came out by the Institute of Medicine. Almost 10% of infants and toddlers have high weights for length. Slightly over 20% of children 2 to 5 years of age are overweight and obese. And approximately 1 in 5 children is already carrying excess weight as he or she enters kindergarten. So, I have been doing research in childhood obesity for about 12 or 13 years or so. And as a pediatrician, I find, and one of the things that I've tended to really feel strongly about is that there's this unique window of opportunity in early childhood. And that early developmental period really does provide opportunities that we don't usually have in other periods of life. So what do I mean by that? Pregnancy and birth to about 2 years of age are the periods of life where we have the most contacts with the healthcare system and the most continuity with our patients. And particularly, I would say, in that birth to 5 years, children are acquiring their eating, activity, and sleep patterns. There are opportunities for establishing healthy eating practices, and just in general, healthy patterns to set them on a healthful weight trajectory throughout life. And with pretty significant or pretty frequent monitoring by healthcare providers, there are chances to identify risks early. So I think it's pretty clear that my interest especially, and I think some of the work that I have tended to do is to really work on what could we do for the youngest children. So when I interpret the trends, you'll see some of my biases emerging. So the obesity epidemic includes even our youngest children. Prevention must start early. In fact, it might even start in pregnancy or as women are preparing to enter pregnancy. We have to search for modifiable determinants at the earliest stages of human development. We have to examine why we are seeing these racial ethnic differences so early in life. And we need preventive interventions based on the best available evidence. And I know you heard from Reggie yesterday about how do you gauge and interpret the best available evidence and put that evidence into practice. So I'm a firm believer in this early life period as a window of opportunity for obesity prevention. But this whole idea of the prenatal period and early childhood as unique opportunities for prevention is not new and is not just relevant for obesity. This is a really interesting initiative that was developed a couple years ago called the 1,000 Days. And one of the main missions of this initiative is to reduce malnutrition. Improving nutrition for mothers and children is one of the most cost-effective and impactful tools we have for poverty alleviation and sustainable development. And I would argue that that is so much more true nowadays with the development of obesity being so prevalent in worldwide, but also in the development of non-communicable diseases and the shift that we are seeing globally from malnutrition to obesity and non-communicable diseases. So my group is a firm believer of this Lifecourse approach to obesity prevention and starting as early as we could for obesity prevention. So if we were to intervene, what would we intervene on? And I put up here some selected determinants of childhood obesity, and some of these are ones where we've done work in our group, but there's really interesting evidence for what we might target during pregnancy, but also what we might target in infancy. And some of these are very familiar to you all. Accelerated infant weight gain, breastfeeding, sleep, duration and quality, which I'll talk about a little bit later, screen time and exposure to food marketing, responsiveness to infant hunger and satiety cues, parental feeding practices, sugar, sweetened beverages, and physical activity. And I bolded the ones that were really ones that came out in the Institute of Medicine report, and that I'll try as we go along to mention some of the evidence, but what were some of the recommendations that came out of the IOM report. So we have a lot of evidence-informed recommendations on childhood obesity prevention and management. For the most part, many of those have excluded children under 2 years of age. Almost all of the national recommendations that were available or are available have really begun with what can we do with the school-age child, or what can we do from 5 and above. So the idea of this this report by the Institute of Medicine, which was funded by the Robert Wood Johnson Foundation, was to really, for one of the first times, try to give some ideas and recommendations for what we could be doing earlier in childhood. And so the audience for this report was people who support parents and families in raising healthy young children, and that included childcare providers, childcare regulatory agencies, healthcare providers, and members of the broader community that influence the environments of young children. So it wasn't written directly for parents, but it was written for those health professionals or professionals who work with children to work with parents to try to achieve some of these recommendations. And the recommendations covered topics related to growth monitoring and screening for overweight, healthy eating, physical activity, exposure to marketing and screen time, and sleep. And for growth monitoring, there were 2 recommendations. The first was what we have come to already use, which are plotting and using the World Health Organization for tracking the growth of children from birth to 23 months of age, and then the CDC growth charts at every well child care visit for children over 2 years of age. But the other recommendation, which I think we all do, but had never really been kind of brought to a recommendation for healthcare providers was, and we get asked this all the time, is how do you identify a child who is on a trajectory for increased risk early in life? And some of the ways to do that was to look at what weight for length they had already attained. So if they were already at the 85th percentile in those first 2 years of life, that obviously is a risk for later obesity. But the rate at which that weight gain was accrued is important. And one of the other things that we tend not to do as much is to acknowledge the parent's weight status. So I wanted to go back to this idea of accelerated infant weight gain, because it's one of the things that we've done. And we've tried to answer this question of to what extent is accelerated growth in early infancy associated with later obesity and its consequences. And we've looked at this in 2 different ways. One was an EPI study, which is the results I'm putting up here, where we studied a pre-birth cohort of about 1,700 children, and we looked at the rate of which they gained in weight for length in the first 6 months of life, and we looked at obesity outcomes at 3 years of age. And we found that the more rapid increase in weight for length in the first 6 months of life was associated with a sharply increased risk of obesity at age 3 years. And that association didn't vary much by birth size. So regardless of your birth size, if you went on to gain fairly rapidly in those first 6 months of life, you had a higher risk of obesity 3 years later. But I'm a pediatrician and I'm a clinician, and I think what we tend to see in the epi literature are z-scores, and that doesn't really translate to what I am doing when I have a patient in front of me. So another way that we took a look at this was to take a look at the growth charts, major growth percentiles that we tend to use in primary care visits. We plot every single child at every single well child care visit, their weight, their length, sometimes the weight for length. But it's one of the anecdotal ways that we are able to identify a child who's at high risk if they have crossed upwards 2 or more growth percentiles. But there was never a study that had actually looked to see whether that, what we all tend to know anecdotally, was associated with higher risk. So we took a look at this phenomenon of whether if a child crossed upwards 2 or more percentiles, if they were at high risk of obesity, and this was at 5 and 10 years later in a electronic health record data set that we have in Massachusetts. And we found that the risk of obesity at both 5 and 10 years of age was elevated if you did ever cross 2 or more growth percentiles in those first 2 years of life. But what was most surprising, and probably not surprising, consistent with the other literature, was that if you crossed 2 or more growth percentiles upwards in the first 6 months of life, that was the most riskiest in terms of obesity at 5 and 10 years later. So that idea that we all tend to use of kind of that anecdotal crossing upwards of 2 or more percentiles, it's real. That is a risk factor for obesity, but crossing upwards, particularly early in those first 6 months of life, seemed to be the most risky. Yes.
Does that include exclusively breastfed babies?
Yes, this includes all feeders. We couldn't go back. This was back when we still hadn't coded for, or still couldn't yet determine how well pediatricians were documenting breastfeeding. But we know that in this group there were both breastfeeders and bottle feeders. So the other recommendations were around physical activity, and this really, the idea was to try to encourage, even at a very young age, for children not to be strapped to some sort of equipment, to try to allow children to have some sort of structured and unstructured play for at least 15 minutes per hour when in childcare, but also providing outdoor and indoor environments for physical activity, not punishing children for being physically active and not withholding physical activity as a punishment, which tends to happen in some of our schools in Massachusetts. For healthy eating, there were several recommendations, some of which we are all pretty familiar with. Breastfeeding, again, was affirmed as the feeding of choice. But there was also, I think, a really nice realization that there are some mothers who, for whatever non-judgmental reasons, cannot or choose not to breastfeed. And I think that while we have a good sense of how to promote breastfeeding, we don't usually have a lot of information that we could give women who do not breastfeed for whatever that reason is. And so there was a real push by the committee to try to figure out strategies that we could provide for those women, which included how to be more responsive to their infant's hunger and satiety cues, and how to allow an infant to self-regulate their own intake, which I think are probably two of the more important reasons that breastfeeding appears to be protective of obesity early in childhood. Avoiding sugar-sweetened beverages, limiting fruit juice, and requiring or recommending that child care regulatory agencies provide safe drinking water to all children in their child care facilities. So sugar-sweetened beverages, and I'm hoping that Dr. Ludwig will talk about this later. Sugary drinks are linked to excess weight gain in all ages, including young children. And actually, David's group had a fantastic study last week in JAMA, New England Journal of Medicine, that again showed the relationship and the association between sugar-sweetened beverages and its link to obesity in adolescents. So there's substantial evidence now that early childhood intake of sugar-sweetened beverages is linked to unfavorable outcomes in adolescence. But the question that I always get asked is, how about 100% fruit juice? So it depends. Again, I see a lot of very young children, and one of my postdoctoral students, who's now a faculty, calls 100% fruit juice the gateway drink. So among children 2 to 3 years of age, it's the second largest source of calories. It provides nearly 100 calories per day. It's associated with increased total energy intake. It parallels soda intake among boys and children in poverty. There's some controversy about its association with overweight and obesity. But even, this is one of the things where even though there isn't sufficient evidence, I can tell you that if a child gets used to or gets programmed to have that kind of sweet tooth that we all think about, early in childhood, there's really good evidence that shows that that's going to track. They're going to crave that sugary taste. And if the first introduction to that is juice, that's probably going to become soda later on. So, I'm a pretty big advocate for eliminating all sugary beverages, and that includes 100% fruit juice. But the other, you have to weigh that against a family who will say, well, that's all, what else am I going to offer them? So in most cases, in fact, the AAP recommends that we try to limit and recommend that parents limit 100% fruit juice to about 4 ounces a day. So depending on where you fall in the interpretation of the evidence, if you believe that it's a gateway drink, or not, those are the recommendations that are out there. Marketing, screen time, and sleep. So the evidence on television and obesity, it really is pointing to the fact that it's the exposure to food and beverage marketing. And so the committee was in the recommendations tried to phrase and frame the recommendation to limit screen time because of that exposure. Not permitting televisions, computers, or other digital media devices in children's sleeping areas, and promoting age-appropriate sleep durations for young children. I just mentioned this, that for quite some time we have thought that screen time is associated with excess weight gain, likely through some displacement of physical activity. But more and more there's this idea and evidence showing that the way that television viewing is associated with excess weight gain is through consumption of unhealthy foods that are marketed on their screens. And so what's the evidence for this, and what is contributing to that recommendation? In 2005, there was an Institute of Medicine report on food marketing and found that children 2 to 12 years of age are strongly influenced by television marketing, food preferences, food requests, purchase requests, and short-term food consumption, and that exposure to food advertising exposure was related to child body fat percent. So it's real. And in fact, earlier this year, there was a study by the Yale Rudd Center that found that between 2007 and 2011, there were more ads for beverages, candy, and snacks, and 7 child-targeted brands, including Reese's Puffs, Fruit Loops, and Pebbles. But the industry is becoming much more creative in how they're targeting advertising for children. There are new advert games, there are new apps, there are banner advertisements on children's websites, on mobile phones and tablets. And for me, as a disparities researcher also, I found most striking was that the most increase in child advertising was in Spanish language television, where advertising for sugary cereals more than doubled and Hispanic children's exposure to those ads tripled. So that's just unacceptable, and it's incredible that we let it happen. So it's real, and this idea of food marketing and exposure to that food marketing and the substantial evidence that shows how that affects children's behaviors and requests for those foods is there. So sleep duration and risk of childhood overweight. I'm going to give a talk later, so I'll try to go through this quickly. So this has emerged as a risk factor for obesity, and it comes from some of the first evidence came from evidence in adults where sleep now and short sleep duration has been linked to almost every adverse outcome you could think of: all-cause mortality, diabetes, early atherosclerosis. And that work started to be shown, similar work in longitudinal studies and cross-sectional studies started to be shown in children. But it was interesting. This was actually for the first time in 2008, the CDC put out maps similar to the obesity maps that they've done, looking at age-adjusted percentage of adults who reported 30 days of insufficient rest or sleep in the preceding 30 days. And what I find most striking of this is the similarities to the kind of obesity belt in the United States. This is the first time that the CDC had put something like this out, and was another more evidence that there seemed to be a parallel increase in short sleep duration with what looks like the parallel increase in obesity in some of these states. About the same time, we published a paper looking at infant sleep duration and childhood obesity, where we found that children who slept less than 12 hours per day, and these were in the first 2 years of life, had a higher risk of overweight and obesity at 3 years of age. And in multivariable analyses in this pre-birth cohort, we found that those children who slept less than 12 hours per day had higher BMI Z-score, higher subscapular and tricep skin fold thicknesses, and increased odds of obesity. And the worst combination for children were those who watched too much television and too little sleep. And if I can show you this with the pointer, those children in our cohort who slept, where's that pointer? Who slept more than, or slept less than 12 hours and watched more than 2 hours of TV had a risk of obesity at 3 years of age of about 17–18%, compared to the children who slept 12 or more hours per day and watched less than 2 hours per day of television viewing, who had a risk of obesity at 3 years of age of about 3 or 4%. So what are the mechanisms relating sleep to obesity? And this I'll cover a little bit more in detail, but a lot of these come from the adult literature. And I think that one of the things that I've stressed to some of the fellows that I'm working with and trainees is that we can't just take evidence that comes from the adult literature. We have to really start thinking about, what are these the same in childhood, and are these similar mechanisms relevant in childhood? So, for example, some of the mechanisms that have been shown are increased hunger because of differences in appetite hormones, increased opportunities to eat, altered thermoregulation, increased fatigue. But where is television? And where are some of the things that children are more likely to turn to if they aren't sleeping enough? And I think that, as with everything in pediatrics, it's important to do our own work in childhood and not just take evidence that comes down the pipeline from adult research. And I'll go through this in much more detail later. So effective interventions in early childhood. A lot of the work that we have been doing is to try to do two things. One is to increase primary prevention and to train pediatricians to be familiar and comfortable with some of these targets for counseling in their primary care practices. But then for secondary prevention is, how do we identify children who are at risk and work to reduce risk in those children who are already attained a certain weight for length or BMI. We have a bunch of different interventions that we've worked on. I'm going to talk just a little bit today about First Steps for Mommy and Me and High Five, but some of these are interventions to really start to promote healthy eating and physical activity among postpartum mothers and their infants. That was our Mommy and Me. That's our primary prevention. And then High Five was a randomized controlled trial that we did in 10 pediatric practices of Harvard Vanguard to really try to work on secondary prevention of children who are already overweight and obese. And so I'll walk you through a little bit of this First Steps for Mommy and Me as an example of an intervention where we were really trying to promote primary prevention of obesity. So this was an intervention to develop and test the feasibility of promoting healthy eating and physical activity behaviors among mother-infant pairs in the first 6 months of life. And we had several different intervention components. We trained all of the pediatricians to endorse mother-infant behavior change using brief-focused negotiation. We had a bit of a challenge. Some of the pediatricians didn't feel comfortable counseling the women on their own behavior change. But once we kind of scripted it for them and gave them ideas of what topics to cover in those visits, At the end of the intervention, they all felt very comfortable. Their self-efficacy increased in their ability to counsel the women on their own health behaviors. The women also received individual coaching by a health educator using more comprehensive motivational interviewing. We matched parent counseling and the educational materials that we provided based on a child's developmental stage, focused on some of those evidence-based behaviors that I showed you, and then allowed for group meetings and convened group meetings, although logistically difficult to arrange, to reinforce the content and to promote that social networking and peer support that we know is so powerful and such a big support for families. These are some of the posters that I mentioned yesterday in one of our meetings. The very first thing we wanted to do was to encourage women to not necessarily think that they had all the answers on breastfeeding. I think one of the biggest mistakes we do with breastfeeding is that we just tend to think that this is going to come so easily to everyone, and that's not usually the case. So what we tried to do was to really encourage women to call us if they were having any problems. So this is from our focus groups where women told us, your breasts don't come with instructions, and I wish my pediatrician had talked to me more about the challenges that I might experience instead of just assuming this is gonna be fine. You're gonna be fine. This is what everyone has done from the moment that from all time. Which I think sometimes makes women feel like there's something personally wrong with them when it doesn't go well. And so we really encouraged that there was support out there, that it's not always easy, and that if you could find the support through some of the services that we were putting together, that we could help them figure out what some of those difficulties were early in those first 4 months, first 4 weeks actually. We gave the clinicians and the mothers materials for promoting the behaviors that we were working on, which were some of the ones that I had mentioned earlier: healthful eating, infant sleep, promoting breastfeeding, reducing exposure to screen time and television viewing. And these were similar to some of the information that you all have put together for next steps. These were all available to the clinicians in their practices, but we also would review them with the mothers during the sessions with the health educators. We put up posters in the practices, again, to encourage dialogue around our behaviors for the infant and for the mom, which the pediatricians loved and the mothers loved, and the mothers really appreciated the opportunity to talk about themselves. At 6 months of age, we found that fewer intervention participants had been introduced to solid foods early. Intervention infants viewed less screen media. We found no differences in breastfeeding duration, and I think I've mentioned this. I mentioned this yesterday. So those posters were so well liked by the providers. We had randomized hospitals, and the rounding physicians would take the posters from our intervention hospitals to our usual care hospitals. So among all of the women, they did really well with initiation and breastfeeding duration, which I guess is a testament to the materials. At 6 months of age, compared to usual care participants, intervention participants had fewer nighttime awakenings, had longer duration of nighttime sleep, and mothers had reduced the amount of time that they spent putting their infants to sleep at night. And we found also, even though the study was empowered to look at differences in weight for length, we found that those infants in the intervention group weren't malnourished, weren't underweight, but were less likely to be in that highest quartile of weight for length at 6 months of age. High Five for Kids is one of the secondary prevention interventions that we did in 10 pediatric practices. It was a cluster randomized controlled trial, 2 to 5 years of age, where we tried to work with children who were already at risk. So children who had a body mass index over the 95th percentile or over the 85th percentile with an overweight or obese parent. So children who we had already identified based on their weight status or their parents' weight status placed them at higher risk of obesity later on. We trained, in this case, nurse practitioners to conduct obesity management visits, so similar to your next step visits, to really guide them on what to cover in those visits with a toddler, 2 to 5-year-old, and their parent. And in this intervention, we found changes in all of our obesogenic behaviors, but particularly changes in BMI at 1 year among girls but not boys, and among lower income participants, which we didn't a priori set out to have changes in girls and not boys, and lower income versus higher income participants. So that was a surprising finding, but did see some changes across the board in these behaviors. And all of the information and the toolkit for this is available online and downloadable for free, as it was an NIH-funded study. So I want to end just with some ideas of other interventions, and particularly the one here on the bottom. So, one of the things that we have tried to do, and that you all have done so much better than some of us in Massachusetts, is the recognition that we need to go outside of the clinical setting and find supports outside of the clinical setting to really boost the effect that we can have in the clinical setting. And so we have funding now to do just that. And these are some of the interventions that we're doing, where we're intervening and hoping to put gold standard models and best practices in clinical settings, but then really trying to engage community sectors to really try to increase the support that families get once they leave our clinical sites. And so one of these interventions is the one on the bottom, Mass in Motion, which is community clinical partnerships to reduce childhood obesity that we are doing with the Massachusetts Department of Public Health, and it's really exciting. And if you invite me to come back next year, I can hopefully tell you how that is going. But the idea of Mass in Motion is that the most effective interventions are going to be those that are multi-sector, that are population-level strategies, and those are the ones where if we try to put into practice the most effective interventions in multiple settings, those are the interventions that are going to have the most, the biggest effects. They're expensive, they're difficult to do. We are now challenged with trying to put into practice in 2 large communities in Massachusetts, Fitchburg and New Bedford, interventions in all of these different settings: early child care and education, WIC, schools. We're doing work in the elementary schools, in the middle schools, in all of the healthcare settings in these 2 communities. And I can tell you it's a big undertaking, but I think that's exactly what we need to do to have long-lasting effects on obesity. So I'll end just with a very brief summary. I hope I've convinced you that the obesity epidemic spares no age group, is of consequence, starts early, and disproportionately affects racial, ethnic, minority children. And for that reason, we should start prevention much earlier and focus on evidence-informed behaviors. Thank you.
We ask that you go to the microphones to ask your questions, though. I'll ask one. So you mentioned that we should recognize the parent's obesity itself. How do you do that in practice?
Yeah, so the way that the Institute of Medicine thought that this might happen, because you're right, one thing is to put out a recommendation, the other thing is how do you actually do that? So it's part of the medical history, and I think it's one thing to, as with our discussion with obesity in children, it's one thing to bring it up in a sensitive way, but also to acknowledge that the parent might also be thinking the same thing in some cases, not all, but the parent might also be wondering if they have put their children at some sort of risk because of their own obesity. And it's usually, I find, more the case that those parents who are overweight and obese, who are coming in early in their children's primary care visits, who are more anxious to find out how they might set a different trajectory for their children. So I don't pretend to know all of the answers of how you might approach it, but I do think that we do a disservice if we don't bring it up and acknowledge it in case there is a parent who really wants to know, what could I do to set my child on a different trajectory than, the parent might have gotten to. So.
Hi, I'm Haimal, and I'm from San Mateo County. I had just one question. It was the high five for kids.
Yes.
In that the intervention was for prevention, so you are not, so the patients who are, the clients who are getting targeted are actually people who may be normal weight or unhealthy weight. Is that correct?
No, sorry. So that was secondary prevention. So those were children who were already overweight and obese, who were then encouraged, and actually were in the intervention, they were supposed to have about 6 visits in the course of a year with a nurse practitioner. And similar to the next steps approach, we would structure those for the nurse practitioner visits.
So the key here was the motivational interviewing part then with the intervention?
Right. So the pediatricians we trained in brief negotiation, which is a little bit different. When we went to get buy-in, so to speak, from the clinicians, motivational interviewing at that point was thought to, when we presented it, it was thought that it was going to take too long, and they had to do this within a well child care visit. And so what we taught them to do was something brief, essentially brief motivation. But the more comprehensive motivational interviewing happened at the visits with the nurse practitioners, where they had more time. And that was a more focused visit just for the weight management. I think, realistically, I think you could probably do brief negotiation in a 15-minute well child care visit. I think to do motivational interviewing comprehensively in a primary care visit is difficult. And I think that's one of the reasons why some of the ideas and next steps is having a structured visit where a parent comes back in and you have a little bit more time to really do the skills of MI is probably more effective.
Hi. Thank you for your presentation. I'm Chris White from Washington County, Maine. I'm an adult and child psychiatrist there in a rural community health setting. I like the slide and the comment about 100% fruit juice being a gateway. And I'm just curious, how much is being looked at in terms of addiction models? I haven't heard much about that. Can you comment on food addiction or sugar addiction in either in animal models or in early childhood studies?
So David could probably do a much better job at describing this than I can, but it's a good point, and it probably is a good model to consider, especially, I would say, when it starts that early, because it might be through the same kind of addiction pathways that children are getting so used to that kind of sweet flavor. We haven't done, in our group, haven't done much with that idea of the addiction model, but there is really good research going on now about just trying to understand if that's the mechanism that we see juice tracking into sugar-sweetened beverages and other sodas or later in childhood and adolescence. But it's a really good point. And
thank you.
I was going to see if David wanted to comment. Maybe you can talk about the addiction model.
Hi, I'm a pediatrician, Steve Blumenthal, and I find that families are most susceptible to our advice, or are very susceptible in the newborn period when we go into the nursery visit. I was wondering if there's anything you're doing currently at a newborn visit along these lines.
Not currently, but I would love to. So, First Steps for Mommy and Me was a pilot intervention, and I completely agree. So actually, I think that you're absolutely right, that these are these kind of windows of opportunity where the likelihood that a parent is going to engage and want to really get that information about what to do in this critical period is probably true at the newborn visit, but in pregnancy. And so I think my ideal next intervention would be to start in pregnancy, start maybe in the first trimester, to really start talking not just about pregnancy health and how to set up that pregnancy for future health for the mother and the offspring, but also, just as you said, try to really start intervening at that newborn visit, which I completely agree.
We don't do as many prenatal visits as we used to, but in the newborn nursery, I often invoke the Hart and Risley study, the meaningful differences in the everyday experience of young children, and try to tell parents that when the baby's eyes are open, the TV should be off, and not because the baby's going to be watching TV, but because it distracts parents from the baby. And people respond. I sometimes, depending on the family, go into details about that study, and I think they're pretty impressed by it. And it's, I think, more effective if I do it then rather than wait until the TV's already been on and try to undo that.
It's so interesting. So, you know, we went back and asked the mothers in this intervention. They knew that TV exposure was one of the things we were targeting. The women went through such lengths to, you know, get their baby not to face the television, to like put barriers rather than turning them off. And at the end of the day, some of the moms said, you know, I need the television on for myself. But it's a good point. I think, you know, it really is humbling when we put together an intervention message that we feel so strongly about, and one of those was exposure to screen time. But humbling to hear that there's a true pushback, and if the only interaction to humans that a mother has in that period with, you know, with adults is through the television, it was really difficult to say, yeah, you should turn it off. So we gave that mother credit for trying to find some sort of barrier for her infant to not, you know, turn his head to look at the television. But I completely agree. Thanks for the comment.
Your point about changing habits, I think, I don't know how many of you know this year that Target knows when you become pregnant.
Yes.
I don't know if you ever know
That's
that.
right.
Women's buying habits change, and so they know exactly, and they bombard you with the diaper because
That's right.
that is a moment of extreme behavior change.
Right.
And I think your comment on that newborn visit and even earlier.
Right. Maybe I should partner with Target.
The idea occurred to me. They may be looking to recoup
Clearly,
a little bit of.
Clearly, they have done a good job figuring out some sort of algorithm for.
You know, we spend so much time here on the marketers as the bad guys, and I think in general I would agree with that. But they certainly have figured out some techniques and some concepts about us. They know us better than probably we all do. So.
Thank you. That's a good point.
Quick question. I'm Allison from Midcoast Hospital, a dietitian. Is it true that England has set up legislation to limit the amount of advertising that children are exposed to for candy and sugary cereals? I don't know if that's a rumor, if there's some truth to that.
I don't know. I know that there is a province in Canada, Alberta, that has very strict rules around marketing to children. In fact, they just presented some of their work in the obesity meetings, where I think so they're not under certain regulation not allowed to do specific marketing of any foods or beverages. It'd be interesting to see the outcomes of that, if it really truly supports some of what we already think, that it's really through that advertising that children request certain foods and food preferences. But I'm not familiar with regulations in the UK. Thank you.